Good morning. I'm Catherine Borganicht, and according to my tag, I'm Master of Ceremonies. I think I'll keep this tag for my team so that they'll know. And I will introduce myself in a moment, but I want Kay to start, Kay Norris, who is sort of our guru in terms of the Montana Pain Initiative. And she's going to do a little housekeeping, and I'm going to do a little intro, and then we'll go from there.
Hello, welcome. It's really nice to have you all here, and we appreciate that you realize that the experiences of pain patients are challenging and sometimes difficult, and that it is worth our while to all come together and talk about these issues and learn from each other and see if we can't reach out and do a better job of helping these people. So thank you for coming. So I will turn you over to Catherine.
Good morning again. I wanted to sort of set the stage a little bit about why we're doing this. First of all, just in terms of the Montana Pain Initiative, we've been around for 4 years now. This is our third annual conference, and one of the things that we realized after our last conference is that we really needed to focus in a little bit more on the primary care physician and how to help those of us who are in primary care provide better pain control, and you're going to be hearing a fair amount about that today. I really would like your comments about what we covered or what we didn't cover that you may need more information about, because we hope to repeat this across the state, so it's really important. Just so you know, the Montana Pain Initiative is a co-project with the American Cancer Society and the American Cancer Society Cancer Action Network, and I really have to thank the American Cancer Society for helping the Montana Pain Initiative get as far as we have. More questions about the Pain Initiative we can answer during the program today, tomorrow at breaks, if people are interested. But I thought I would like to set the stage and sort of tell you about my week. I am a geriatrician and an internist, and I run a local hospice and palliative care program. I'm not a chronic pain doc, but I see a lot of people with pain. And I just thought I'd give you a flavor of what I, as a primary care physician, face weekly, and that I suspect a lot of you who are practitioners, either primary care docs, nurses, or whomever, face on a daily basis. So my week started actually at the gym, and I have a regular class that I go to every week at the gym, and there are anywhere between 4 to 8 women who are in this class, and we work out pretty hard, but we have a really good time. So I was talking about the conference that was coming up and my anxiety about it and people coming and all this kind of stuff, and one of them volunteered. Well, she was a recovering addict, and she didn't think anybody should take pain medicines, and that she avoided them, and that any pain medicine was addictive. So that was the first conversation. The second conversation, which continued in the locker room, was a woman whose husband is a chronic pain patient, and not only does he struggle with not wanting to take his pain meds even though they make him feel better, but she also talked about going to the pharmacist and them looking at her askance because she had a legitimate prescription for pain medicines, but they thought that perhaps she was abusing. Okay. That was the beginning of my week. Then I went to my med exec committee at the hospital, and we had a conversation about chronic pain patients in the emergency room, how that's not the appropriate place, how they need to go to their primary care physicians, and I raised the question of, well, do we have primary care physicians in our community who will take care of these patients? Didn't get answered. That night I spoke to my sister, who's a chronic pain patient who was having a pain flare but didn't want to take her pain medicines. Then the next day I did hospice rounds, and there were 2 issues that came up, well, many issues that came up, but one was an issue of a patient in an assisted living place where the people at the assisted living place did not want to give her pain medicines. This was a confused patient, and she was lying in bed with a dislocated shoulder and a broken hip, but they didn't think that she really needed her pain medicines around the clock. The other issue that came up was a family who did not want to give 2 Vicodin a day to a patient because they were afraid she might get addicted. And then there was the hospitalist in our facility. One hospitalist wanted to give a chronic pain patient their medicines. Another one said, no, we need to get her off all the pain medicines. Then I got emails all week about Tylenol. Everybody knows about the Tylenol controversy, how they want to take Tylenol out of Vicodin, out of Percocet, and that this could be actually a major problem for those of us who do pain management. In the meantime, in my office, I saw 17 geriatric patients each day. Okay. And then finally, I ended my day with a meeting last night of the Quality Council for our health group. Pain did not come up as a quality measure. And then finally I got home, and there was this lovely little magazine, which I'd never seen before, called Pain Solutions. And I just started flipping through it this morning, and I can make it available for people to look. But this is just 1 week of dealing with pain and the issues that come up, and I'm sure that this is pretty familiar to people. I'm running out of time, but I want to ask real quickly who people are. So can we start with nurses? How many nurses are here? Great, that's terrific. Social work? Physical therapy? Let's see, doctors. Oh, that's great, excellent. Who am I missing? I'm sorry? Mid-levels. Oh, mid-levels, that's right, or non-physician providers. Great. Pharmacists, yes, very important. Great. And what about chronic pain patients or patients with pain? Okay, great. Okay, so again, I'm very excited about this conference. Please give us your feedback because we really need to know it so that we can do better next year. And I am now pleased to introduce June Dahl, who, if anybody is a guru, to me, it's June. June comes from the University of Wisconsin, and she's got a huge CV, of which I'm not going to go into, but I'm just absolutely so delighted that she's here because she will set the stage for what I hope is a great meeting.
Thank you very much, Catherine. I have to find my slides. So let me just get a moment to do that. There you go. Thank you very much. I must say it's really an honor to be here. I have come to Montana several times now and been witness to the growth of this movement. And it's really, really exciting. I almost feel like an honorary citizen of Montana. And if it weren't so far away from Wisconsin, I might spend more time here. I've been asked to set the stage in a way, to talk, as you can see from the title and from the slides you have, about pain, to give you an overview, to talk about its prevalence, to talk something about pain mechanisms. I'm going to talk about the types and prevalence of pain, impact that under-treatment has, something about the basic pain mechanisms, especially emphasize the multiple dimensions of pain. And I think Catherine clearly sees that in her practice, the complexity of this symptom. And then end with just a very few comments about challenges and conundrums. I don't have to tell all of you that pain is a very common human experience. Sometimes pain is good. It really is a warning sign that something is wrong with our body. But if it persists, it's harmful to the body and to the mind. And I can't find that pain really has any redeeming virtues. It doesn't make us better people. And sometimes I get the sense that because people don't want to treat pain, they somehow feel it's good for us. And we know now that even short-term pain can be harmful, and that acute post-op pain delays healing. It's a risk factor for the development of chronic pain. And there's lots of evidence that pain is inadequately treated. I've been in this business of trying to see things change for 30 years, and I'm pretty disgusted by the fact that we have such high percentages of people whose pain is not adequately controlled. It seems, as Betty Farrell said at one time, that this problem really should create moral outrage in all of us. We just shouldn't stand for it anymore. And there are lots of barriers. And you heard some of them, at least from Catherine. Lots of myths and misunderstandings, and certainly confusion about what the right thing is to do, even among healthcare professionals. We also have to take a moment to reflect again on what pain is, because it's not a disease, it's a symptom, but it's got lots of elements to it. It's a sensory experience, but there's also this critically important emotional component. And we can have pain even though no one can find any overt damage to any organ system. So it's sensory and emotional, and that's why I've liked Margot McCaffrey's definition of pain, which she coined way back in 1968 before some of you were born. She said pain is whatever the patient says it is, existing whenever he or she says it does. And that's because we don't have any instrument to measure pain. We don't have a pain-mometer that we can stick in some orifice and say, woo, that person has pain of 10 and it's neuropathic. Unfortunately, the only thing we can do is to believe the patient's report of pain. And that at the very outset is one of the major challenges in this arena. Now, we need to classify pain. And we need to do that because that directs us as to how we should approach treatment. And there are many different ways you can classify pain. By its intensity, how severe is it? Mild, moderate, or severe? How long it lasts? Is it acute or chronic? What its pathophysiology is. Is it nociceptive or neuropathic, or is it inflammatory, which I haven't included on this slide. And then we also have to think about the type or the syndrome, whether it's cancer-related, whether it's low back pain, fibromyalgia, migraine, or pain associated with sickle cell disease. If we think about duration, we have basically short-term pain and long-term pain, acute, and there are lots of common causes, and then chronic, that persists beyond the time of healing. The geriatricians have decided that instead of using the term chronic, they would prefer that we talk about persistent pain because it's a less pejorative term. It doesn't have quite the negative connotation. You know, there are people who call me who have chronic pain. They call me on the phone because they don't have, their doctor doesn't have time to talk to them. And I sometimes have trouble liking them over the phone. So I can't imagine what it's like for those of you who confront these people in your office. We can also classify chronic pain into different types. There's some that comes and goes, and migraine is very common. And then there's cancer-related pain and pain that's not related to cancer, but goes on and on for the lifetime of the individual. We also need to classify pain based on its pathophysiology. And there are two major types, nociceptive and neuropathic. And we'll talk about nociceptive mechanisms. A lot is really known about them. But nociceptive pain comes when there's damage to muscle or connective tissue or to something surrounding bony joints or soft internal organs. And people tell you that they have that kind of pain because of the way they describe it. It's dull or aching or throbbing or cramping. And there are two kinds of nociceptive pain. There's somatic and visceral. And we can distinguish them because, for example, for somatic pain, the person feels the pain right where the lesion is. And an excellent example comes from somebody who has a bony met. If I have a bony met to this hip, I will tell you as the provider, it hurts right here. And it's dull and it's aching and sometimes it throbs. If it's visceral pain, then the pain may not be at the site where the lesion is. And a good example is the pain of myocardial infarction, where we don't feel it in the heart, but it may extend down the arm, it may go up the neck, maybe in other places. Neuropathic pain is different. Here, instead of the nerves carrying the pain messages, the nerves become the generators of pain signals. And there may be problems in the peripheral nervous system or in the central nervous system. And you know that people have neuropathic pain because of the words they use. It's sharp or burning, or there may be numbness or tingling. And there are two phenomena that one often sees in persons who have neuropathic pain.
One's called allodynia. That means that folks get pain even from a non-noxious stimulus. They'll feel pain if a breeze moves over their limb, for example. There's also hyperalgesia, and you can kind of figure out what the term really means. What happens in that instance is that people have an exaggerated response to a noxious stimulus. So if you just do something that's very mildly noxious, they will feel tremendous pain. And then when we talk about the pharmacologic management of pain, our understanding of duration, of pathophysiology becomes very important, because for nociceptive pain, non-opioids, acetaminophen and non-steroidals, often provide good relief if the pain is mild, and we need opioids if pain is moderate to severe. For neuropathic pain, although opioids will work, one often needs to turn to a whole different class of drugs, and you'll be hearing about these. Hello, I'm not talking loudly enough?
And it's not your fault, but we're going to fix it at the break, but if you could talk right into the
I will talk right into the microphone. Thank you. I'm sorry. You should have yelled. You're too placid an audience. I hope you'll get a little more obnoxious later. So, as you know, for neuropathic pain, one turns to drugs which were not originally released to treat pain. Antidepressants, antiepileptics, local anesthetics. And yet, despite the fact we now have a pretty good roster of medications and other therapies to treat neuropathic pain, the outcomes of these treatments are really not very good, because we know that despite heroic efforts, pain, if folks have neuropathic pain, remains unrelieved in 40 to 60% of patients. And that's really a tragedy, and that's why it's so important to prevent neuropathic pain. And certainly, since diabetics develop neuropathic pain, one of the things we have to work very hard to do is to control their blood sugar. Because if one does, then that will diminish the onset of neuropathies and the pain that accompanies them. And the one exciting thing that's occurred over time is the development of a vaccine against the zoster virus. And that's been found, in fact, to diminish the likelihood of our developing postherpetic neuralgia. And we have to think about, and I know researchers are thinking about, new and different ways to prevent the development of neuropathic pain, since it's so hard to treat. So here's our bottom line, and you heard about this from Catherine in many ways. Pain of all kinds is still inadequately treated. It's a major public health problem. And if we look at the numbers, and we'll look at them just very briefly because they're in your slides, it's been estimated about 750,000 people have surgery every year, and of course, a lot of them have pain, and a lot of these surgeries are in the outpatient setting. And we have many studies to show that these folks have a lot of pain. And what is really annoying to me is that we have data that show that pain is more poorly treated after people get out of the hospital than when they're in the hospital. So they report more pain after they get home than they do when they're hospitalized. And what we need to do is to be setting up systems so that folks who have surgery and are discharged very quickly know whom to call and what to ask if they go home and their pain is not adequately controlled. And there are also data that are very disturbing that show that because folks know that surgery causes pain, and that often post-surgical pain is not well treated, that they'll put off having surgery because they're worried about the pain. And this acute post-operative pain, when it goes unrelieved, has a lot of negative clinical outcomes. There are effects on the cardiovascular system. There are effects on cognition. There are effects on the immune system. So we can document lots of good reasons why pain should be controlled very effectively in the post-op period. And then there are a lot of economic complications because, again, if pain is not controlled well, this diminishes healing. This increases length of stay. Also, there's evidence that pain is a cause for readmission to the hospital after folks have been discharged after a surgery. And then what I mentioned before, and needs to be thoroughly emphasized to people who say, it's just pain, it's no big deal, is that when acute pain is not adequately treated, it's a risk factor for the development of chronic pain syndromes. The nervous system is not static, it's dynamic, and it undergoes changes. And so we end up with persistent pain problems. Cancer pain, still a huge problem. And this is the thing that absolutely boggles my mind, and it's unacceptable. I started advocating for better pain control by focusing on persons with cancer because at that time there wasn't a lot of controversy. People knew what to do. They just weren't doing what they should be doing, and people were hurting. But again, the data that have just come out from the American Cancer Society Cancer Action Network tell us that we still have pain in 60% of people undergoing active treatment, that more than 60% of people with advanced disease have pain. Maybe that's a little better. I think I used to say 75% of people with advanced cancer have unrelieved pain, but you see we haven't made a lot of progress. Other thing that's very critical is that cancer has become a chronic disease, and survivors are living longer and longer with pain, and that pain may be associated with their treatment, with their radiotherapy, with their chemotherapy. So I've given you a reference that I suggest you read, because what's happening is people with cancer are becoming classified in the whole family of those who have persistent non-cancer pain. And these folks are in the millions in terms of those who are suffering. The Centers for Disease Control did a survey, issued a press release 3 years ago, and I strongly advocate you go online and look at the results of that survey. They found that 20% of persons over the age of 65, if they looked at them in the past month, had pain, and that pain had persisted for more than 24 hours. And a lot of people had pain for more than a year. And then there's that back pain. If somebody could figure out how to treat back pain, they would certainly get the Nobel Peace Prize at the very least, if not the prize in physiology and medicine. And the CDC's study found that a quarter of adults had low back pain in the past 3 months. And then 15% had migraine or severe headache. Headache is really the last frontier for many people. And then when we think about the geriatric population, and that's the population that Catherine serves, and that's the population in which I reside, high percentages of people in long-term care have inadequate pain management. There are data that show that 1 of 4 residents of long-term care facilities get no treatment for their pain. And we came to Montana, was it a year ago or so, and had the privilege of working with long-term care facilities and had a chance to ask patients, these were not cognitively impaired, these were cognitively intact patients, about their pain experience. And 40 to 60% of those reported to us that they had moderate to severe pain. This is unacceptable. What are the numbers? Well, these numbers are a little out of line, but that's all right. You can see the list: back pain, arthritis, headache, diabetes, cancer, osteoporosis, fibromyalgia, HIV/AIDS, and then of course sickle cell disease, which is not a tremendous problem, I suspect, in Montana, but is a humongous problem in states in the southeast of the United States. And these folks are usually African American, and it is certainly true that African Americans are much more likely to abuse drugs than are Caucasians. I hope you've got that imprinted in your brain. Sad case. So all this uncontrolled pain has lots of costs. They're physical, psychosocial, they're economic. And there was a paper published in the New England Journal, JAMA, in 2003 that documented the economic consequences of just the pain associated with osteoarthritis and back pain. And one of the things that struck me is we always think that people who have chronic pain don't want to work. And of course, absenteeism is what costs society so much. I have back pain, so I don't go to work. I have osteoarthritis, so I don't go to work. Well, that study showed that the major costs, the major economic costs of these common pains were not due to the fact that people didn't go to work, but to diminished productivity on the job. So they went to work, but because their pain was not well treated, they could not work effectively. So we have to think about some of our ingrained perceptions of people who have persistent pain problems. So enormous societal costs, unnecessary suffering, and these huge numbers, over $100 billion. I don't even understand these numbers. 50 million lost work days in the US. And then, of course, what I already mentioned to you, if people have surgery and have pain, we have these other economic societal costs, increased length of stay, readmission for pain, and delayed healing. Healing is delayed when people's pain is not well controlled. And then all of the other factors, depression and hopelessness, impaired mobility, impaired physical function, decreased socialization, cognitive dysfunction. You know, we often think that when people get older, they're just naturally going to have diminished cognitive function, right? That again is another one of the truisms. But in fact, it's been clearly documented that a lot of the cognitive dysfunction is a consequence of unrelieved pain. And you can think about that yourself. You aren't cognitively impaired, but pain will prevent you from making good decisions, from having good motor skills. And of course, all of this increases healthcare utilization. And then we've got to mention sleep disturbances. These are very prevalent among persons with pain. And interestingly, people with fibromyalgia have significant sleep disturbances, and these abnormalities may in fact be tremendously important factors in explaining the pain that they experience. An investigator did a study with healthy medical students and did sleep deprivation, similar to that experienced by people with fibromyalgia, and guess what? They started to hurt. They started to hurt all over. They started to feel like they'd been run over by a semi, and that's how fibromyalgia patients often describe their pain experience to me. So why is pain undertreated? Well, you know the routine. There's a lack of knowledge, there are inappropriate attitudes, there's our health care system, and you'll notice I put care around, quotes around care. I don't know how much caring there is. There's a lot of costing. There's the drug regulatory system, there's the reimbursement system, and we have all these folks who have no insurance. Among patients and families, there are all sorts of barriers that have been documented in the literature. In Wisconsin, we have a lot of stoical German and Scandinavian farmers, and they don't want to talk about their pain. They don't want to complain. It's really good to be stoic. There's the belief that pain is inevitable, or that you deserve it because you haven't been a good person. There's the fear of what the pain really means. It means something is really wrong with me. And if I go to a doctor to find out what that pain is due to, then I may be in for all sorts of problems. There's the fear of addiction. And then people don't even know what addiction is. And there are a lot of negative experiences or attitudes about analgesics. Catherine articulated those well. There's another thing is, I go to my doctor because I have something wrong with my body, and I don't want to take away precious minutes for that person to be looking at pain. And then there is the belief that you can't manage pain, especially among older people. It's just something I have to put up with. And then all these barriers in the healthcare system, which I do not have to read to you. And then notice the fifth bullet point, restrictive laws. Well, there may not be restrictive laws in Montana, but there's attitudes that there are, and now we have, and this slide is not in your handout material, the FDA has recently gone a little mad, in my unbiased opinion. They want to require REMS, risk evaluation mitigation strategies, for all opioids. What do these mean? Well, some of the plans suggest that we should have patient registries. And anybody on an opioid should be on a special registration list. I'm sorry, this smacks of fascism to me, and some other awful things, but of course one of my problems is that I'm not opinionated about anything. And then there is the recent action that Catherine alluded to about acetaminophen. So the Food and Drug Administration, in its wisdom, because it says that acetaminophen is a major cause of acute hepatic failure, is that we ought to take all of the opioid acetaminophen combinations off the market, period. End of quotation. And that also we ought to make the 500 milligram acetaminophen tablet, which is now available over the counter, prescription only. We need to talk about this because the Montana Pain Initiative needs to make some statements to the Food and Drug Administration, and the deadline for the comments about the acetaminophen regulations is September 30th. You've still got time. Now I want to talk briefly about mechanisms because these provide the background for assessment and treatment strategies, and because it's so important to understand how much progress has been made in understanding what happens in our bodies when we experience pain. So I'm going to show you some pictures and we'll go over this very quickly, and I suspect it's going to be revisited by people who talk about pain management strategies. Pain is sensed by nociceptive neurons. That means neurons that respond to noxious things in the periphery. For example, I have these nociceptors in my fingers. And what happens is when they get stimulated by noxious things, then they carry signals down my arm and into a region outside my spinal cord, then into my spinal cord, and then up to higher centers of the central nervous system. So we've got these connections with spinal neurons, and some of those spinal neurons extend into the brain, and other spinal neurons form circuits in the spinal cord. Then we have, as I'll show you very briefly, interesting things where we have descending pain inhibitory pathways that actually interfere with these transmitting messages up the central nervous system. The nociceptive system has 4 components: transduction, transmission, perception, modulation. And this diagram shows you the pain pathways, and maybe there is a pointer here somewhere. Is there? Okay, a laser pointer? Well, I'll point with my finger. So you see, here we have the pain pathways, and there is a noxious stimulus. Notice that tack that is hitting those nociceptors. Oh, here's the magic bullet. Here we have those nociceptors, those pain receptors, being stimulated by this noxious thing, which is a tack. And then this stimulates a message to be transmitted to what are called the dorsal root ganglia, then into the dorsal horn of the spinal cord, then up to higher centers of the central nervous system, into the brain, where we recognize that we are hurting. So those primary sensory neurons are activated by stimuli that cause tissue damage. That can be heat, it can be pressure, it can be irritating chemicals, and normally these are not stimulated by simple things like warming or light touch. But people who have allodynia may respond to non-noxious stimuli. They may feel pain. So here we have this transduction mechanism. And we have, I see my tack moved since last night. We have the noxious stimulus, which is the tack, stimulating these nociceptors in the periphery. And you see this is what is the beginning of the perception of pain by our bodies. So impulse generation begins there at that site, and there's an increase in the permeability of those membranes to various ions. And what happens is sodium moves across, and that input of sodium depolarizes the membrane, and it activates a burst of energy, of neuronal signals that are conducted into the dorsal root ganglia and then into the dorsal horn of the spinal cord. And what are dorsal root ganglia, for heaven's sakes, for some of you who don't know neuroscience? These are cell bodies of neurons that lie just outside the spinal cord, between each vertebra. And they send axons not only out to the periphery, but into the spinal cord. And that's demonstrated in this particular figure, where you see we have stimulation here at these peripheral pain receptors, these receptors to noxious stimuli, and then the message is carried along these neurons into the dorsal root ganglia and then into the dorsal horn of the spinal cord, which is right here. And this dorsal root ganglion is awfully important because it makes a lot of neurotransmitters and a lot of other proteins, and they go back to the periphery and also forward into the spinal cord. So the messages, this is the transmission piece, are carried from the site of transduction, that's the periphery, where my nociceptors are, through those dorsal root ganglia into the spinal cord. And then there are a lot of transmitters that are released in the spinal cord, and they activate receptors, and when there are sufficient intensity, then these excite other neurons, and the nociceptive impulses ascend to higher centers of the central nervous system, and this is transmission. So we see that the message comes in from the periphery, goes from the dorsal root ganglia into the dorsal horn of the spinal cord, it crosses over, and then there are messages that are transmitted up to the brain, in particular to the thalamus, and that's where perception occurs. This is the process by which we recognize that we have pain. And this thalamus that you saw sends input to other parts of the brain. And there are many processes that occur within the brain itself. And what happens when the message reaches the brain and affects these different centers there, that the sensory information that came from the periphery went into the dorsal root ganglia and into the dorsal horn is combined with emotional, cognitive, social, cultural determinants to create the pain experience. So although we have these processes for perceiving a noxious stimulus, we've got to recognize that once the message gets to the brain, there are lots of components of the brain that combine that sensory information with our current emotional status, with our cognitive status, with the socio-cultural environment in which we live. And those ultimately create the pain experience. So here we see these components of the brain. And the message comes first to the thalamus and then goes to the sensory cortex and also into the limbic system, which is very much involved in our affective response to pain messages. Now, all that we've talked about so far are things going up in the nervous system, the upward trajectory from these nociceptors into the spinal cord and up to the brain. But what's critically important is there's also a descending system. It's not all about signals going up, it's also about messages coming down. And this is where modulation comes in. There is a descending system that influences the transmission coming upward in the spinal cord. And somehow, stimulation of certain regions in the midbrain activate neurons that then descend back down to the spinal cord. And these neurons release a lot of important neurotransmitters like serotonin, like norepinephrine, and even opioid peptides. And that inhibits ascending pain impulses. There are recent data to suggest that, in fact, acetaminophen may work on descending pain inhibitory pathways. We haven't really ever understood how acetaminophen does provide relief of pain, and we know it does. So this pain modulatory system is very important. A paper that was published this month in the journal Pain suggests that people who have irritable bowel syndrome, people who have TMJ pain, even people who have fibromyalgia, these are really serious chronic pain problems, may have some deficiencies in these pain inhibitory pathways. And that's the reason that they have chronic pain. So there's an enormous amount of research going on to look at these different components of the nociceptive system to find out, are there abnormalities in those different components in people who have persistent pain? And also, very importantly, of course, to find drugs that will affect those different components. So this is the picture of modulation, where the messages come in from the peripheral receptors and goes into the dorsal root ganglia. And some of you may hope that you never hear about dorsal root ganglia again in your lives. But they're in your body, and they're darned important as far as pain transmission is concerned. And then the message goes from those guys into, or maybe they're gals, into the dorsal root ganglia. There's more transmission up to higher centers of the central nervous system, where we perceive these noxious stimuli have been at work in the periphery. And then there's this descending pain inhibitory pathway. And maybe folks who have certain persistent pain problems have some dysfunction of this descending pathway. And that's why they have persistent pain. Now, you know also, some of you, that you can rub parts of the body and get pain relief. And there are, in fact, mechanoreceptors, which if you rub them, can in fact also inhibit pain transmission, and in that way modulate the pain experience. So what was all of that about? Maybe you went to sleep during that time. It's much more than a neurobiological process, however. It awakens fight and flight mechanisms, it elicits emotions, evokes memories of past experiences, past painful experiences in particular. And we have to recognize that pain is a multidimensional phenomenon that, again, as I've said, evokes cognitive, behavioral mechanisms, as well as these chemical and electrical mechanisms that I try to portray for you in those words and in those figures. So these multiple dimensions of pain, sensory, emotional, behavioral, cognitive, sociocultural, all of these are critical elements. And these multiple dimensions are what make your work so challenging, because it's not just about affecting nociceptive pathways. It's not just about understanding more about what's going on in neuropathic pain. It's looking at the whole person and how complicated that person is. So I've given you some figures, and I think for the sake of time, I will not go through these in detail. We can, but I simply wanted to emphasize the complexity of the pain experience. So there's the sensory, emotional, and spiritual aspects of pain. There also is, very importantly, the behavioral components, because we become angry, we become depressed, we become anxious when we have pain. There's the cognitive element, and that's why behavioral and cognitive therapies become so important. And then there are all these social-cultural phenomena. There's the effect of age and gender and of the environment in which we grow up. All of those affect the pain experience. So it isn't surprising that since the pain experience is multidimensional, that the intervention should be multidisciplinary. And you'll be hearing more and more about that throughout the course of this 2 days. I'd just like to mention to end that we've had progress. Although I lament the fact that the percentages of people with unrelieved pain seem almost to be immovable, we do have greater awareness of adverse effects of pain. We understand that we need to better control pain. It's not something we can ignore. We have new drugs, new delivery systems. There are numerous professional and advocacy organizations. We have the American Academy of Pain Medicine for docs, the American Society of Pain Management Nursing, an organization of nurses solely focusing their attention on pain. The Joint Commission in 2001 began to score for pain assessment and management, and the VA has made a tremendous commitment to doing a better job of managing pain for our veterans. Despite all that progress, and your being here is a critical indication of the progress that has been made. We didn't see these kinds of things 15 years ago. When I started with the Wisconsin Cancer Pain Initiative way back in 1986, there were no national efforts, none, zilch, dedicated to pain management. But despite the progress, and it's real, we have a lot of concerns and challenges, and I would say conundrums, a lot of uncertainty, and Catherine articulated those. Confusion about the role of opioids in the management of chronic non-cancer pain. We have an increase, unfortunately, in opioid misuse and abuse. And then another tragic thing is that pain medicine is fragmented by competing disciplines. So instead of people working together, we find unfortunate fragmentation. And it's nice to know that at this meeting, the different disciplines are coming together to speak with one another. So pain is obviously a lot more than an unpleasant sensation. We recognize it as a biopsychosocial experience, and recognition of that is essential to all aspects of the care of persons with pain. We have to understand the physiology of pain. I may not have provided you with that knowledge in that brief time period, but one has to have that as a framework for appropriate pharmacologic and non-pharmacologic therapies. Those form the basis for treatment. Unfortunately, much pain is still inadequately treated because we still don't have the knowledge we need, and we still have a lot of inappropriate attitudes. And then we have this crazy healthcare system, which certainly does not facilitate good pain care. It's been written that pain management presents a glaring example of the disparity between the current state of medical knowledge and the prevailing custom of medical practice. I would say this is not a gap, it's a chasm. It's a chasm. There's a lot of knowledge out there, but it's not being applied. It's not part of the prevailing culture of medical practice. So I thank you profoundly for your ongoing commitment to eliminating the disparity and for working together to reduce the suffering of citizens of the state of Montana, and also for recognizing that the quality of pain control is everyone's responsibility. We can't let it be in the hands of one discipline or another. So I want you to use this conference to the maximum of your ability to charge your batteries and to come together and understand what each and every one of you brings to the table. And I wish you much success in these 2 days, and I compliment the organizers of this conference for doing a fabulous job of bringing you together. It's wonderful to see this many people this early on this Friday morning. It is Friday, isn't it? Coming together to really work to make a difference. Thank you so much.
I realize in the title of this first talk is Pain Management and Office-Friendly Approach. I have to say that with tongue-in-cheek because I'm not sure there is an office-friendly approach, and hopefully we'll come up with some ideas during this conference. But it is bigger than this talk can possibly contain, and I have some thoughts at the end of this, if we have time to discuss that. This is really the beginning of Pain 101, which is basic pain management and trying to give those of us in primary care somewhat of an organized approach to how we deal with chronic pain patients or patients with persistent pain. I agree about that. Chronic pain, it has a lot of pejorative associations with it. I just wanted to mention one thing. On one of June's slides, she talked about the VA commitment. The first time I ever got involved with dealing with issues around pain and the 0 to 10 scale and that whole thing was actually in 1990 when I was working at the VA. And they did a big Institute of Health Improvement program that involved the VAs across the country. You can see really how slow things move in this arena. a great thing that the VA is doing, but it also is taken many, many years for them to get even this far. The other thing I wanted to mention, and I did list this in one of my slides, is a book that I've come to rely on a lot. And I would really, really recommend it to people. It's written by Lynn Webster, who's a physician in Salt Lake, and Beth Dove, and there's a foreword by Stephen Pasek, who's been involved in pain management for a long time. It's Avoiding Opioid Abuse While Managing Pain. And for those of us in primary care where this is an issue, I think it really provides a lot of guidance for you. Some of the things that I'll be talking about are actually in this book. They're also in your appendix in terms of forms that you could use in your practice. So again, I would really recommend that everybody at least have one copy in their office. Okay, so what we're going to do here is I'm going to talk for a little while about assessment, and then my partner, Deanna Brame, who's a clinical nurse specialist who works with me in the palliative care program, is going to talk about the middle piece of how do you really assess pain in the office, and then I'll finish up with talking about abuse. So I see here several good deeds that seem to have gone unpunished. This is a slide, those of you who've heard me talk before, I use frequently. My father always used to say this to me, and I always sort of think when I'm doing these talks and cogitating on them the night before and not sleeping and having my anxiety attack about it, that this is what this is all about. So what I want to do is I'm going to define the problem a little bit. We've heard a little bit about that. Understand the limits of care, and then describe various strategies, including some assessment tools that you have in your handouts that hopefully we can use in the primary care setting. So we've heard about this but this is from a slightly different perspective, and I think it sort of defines the problem for those of us who are in primary care. We have 6.5 million chronic patients with persistent pain in the United States. I'm going to try to change my language. It's like using opioids instead of narcotics, and we can talk about that as a name. There are 120,000 primary care providers. There are, however, 6,000 pain specialists across the country. Okay? So this is really a primary care conundrum, as June said, and a primary care problem. We have got to, as primary care physicians, figure out how to deal with this. There are many issues, and I'm going to go through some of them. Practice issues, definitions, which I will talk about a little bit. Talk a little about what my experience has been, and then some changing thoughts and some data. This is from an article that was written in the New England Journal of Medicine. The most difficult issue now facing physicians is whether and how to prescribe opioid therapy for chronic pain that's not associated with terminal disease or is associated with patients with cancer that are living with pain, including pain experienced by the increasing number of patients with cancer in remission. So that's the problem. So some of the things that are practice issues for us as primary care physicians are that, like other chronic diseases, congestive heart failure, diabetes, rheumatoid arthritis, they really lend themselves to disease management, and that is what we do in primary care. Okay. However, we have limited time. I mentioned that earlier, that I saw 17 patients in my office yesterday and had a meeting that I had to go to, and had to deal with electronic medical records, which is a whole nother conundrum that I think we face. And it's got the good and the bad, but I think it does raise some real issues for those of us who are in primary care as to how do we see these patients. Pain is just one problem, particularly in geriatrics. I mean, you know, it's one of the it's on the list, and I just on Tuesday I had a patient who I'd been through this whole list. I said goodbye to her, and then she turns around and says, "Oh, by the way, my back pain." And I'm like, okay. I think there may be some unrealistic expectations both from us as providers and from patients and from society in general. There are attitudes barriers, and then there are the whole issue of resources. We've talked about some of these practice barriers. They're patients, they're professional, and they're systems. And we'll go into that a little bit more. Patients, again, they are so afraid of that word addiction. It just is stunning to me. I mean, I cannot tell you how frequently I hear that. I do not want to get addicted, so I'm not going to take this pain medicine. And then from professionals, I hear, well, I don't want this person to get addicted, but really, I don't want to be sued. And that's really the liability issue for those of us who are professionals is misunderstood and very large out there. And then there are systems issues. How do we get these people in? How do we approach them? How do we deal with them? And we've heard also about some of the things that the government is doing, and we'll be hearing more about that tomorrow. So patient barriers, again, fear of addiction, fatalism. Okay, I've got pain, there's nothing you can do about it. Good patients don't complain, concern about side effects, concern about masking disease. This came up just this week again. One of the patients didn't want pain medicines because they were afraid that it would mask whatever was going on. When I was in training, it was, people who came in with abdominal pain, you never gave them any medication for pain medicine because then you might not be able to figure out what their problem was. Well, we know that that's not true anymore, and of course we have better imaging than when I was in training. I won't tell you how long ago it was. Professional barriers, knowledge, low priority, values and beliefs. We talked about this a little bit, but I do want to talk about the low priority issue, because even though pain is one of the most common symptoms and common reasons why people come to see the primary care physician, come to the emergency room, come to the hospital, it's not a priority. And I see this again and again. It's not a sexy disease, okay? Dealing with pain isn't sexy, okay, in many, many ways. And as providers, we want to get jazzed about stuff. We want to be excited about things. And unfortunately, pain is not one of those things that's really that exciting, except for those of us who do it all the time. Studies continue to demonstrate clinicians often revert to conservative analgesic treatment to avoid scrutiny. We are afraid of whoever is out there, and we don't really know who's ever out there at this point. When I was in California, I practiced for many years in California, and there we had triplicate prescriptions. Does everybody know what those are? So in order to write any kind of opioid prescription, you had to have these special prescription pads that had 3 copies in them, and you gave 2 to the patient, 1 you kept, and the patient took them to the pharmacist, and the pharmacist took both copies and put 1 copy somewhere. Well, I have this image of these big boxes somewhere in the state of California filled with these triplicate prescriptions, and nobody ever looked at them. I mean, they had no influence on anything, but they're just sort of were there. They've gotten away from that in California, which is good. But for many, many years, there were physicians who wouldn't even bother to get triplicate prescriptions because they figured that was a good way for them to avoid having to prescribe opioids. I remember I went to the emergency room with my husband once who had kidney stones. This was in San Francisco, okay? Big town. Nobody in that ER had a triplicate prescription. I had to write a triplicate prescription for my husband who had kidney stone pain. It was pretty stunning. It was interesting. And then finally, I think this is a really important quote. The consequences of overtreatment are deemed less acceptable than undertreatment. Okay? So we're so worried about overtreatment, but we're really not thinking about those people who are walking around with pain. William Osler, it's much more important to know what sort of patient has a disease and what sort of disease a patient has. I just read In My Country. I don't know if any of you have read that by, his last name is, I apologize. But anyway, this is a doctor from India who worked in Tennessee and worked with a bunch of AIDS patients. And the book was really fascinating for a lot of reasons. It's a great book to read. But he spent a lot of time sort of knowing who these patients were. These were all patients who had HIV or AIDS, and telling their stories in this book. And it made me remember in my 17 patients a day, how much am I getting their story, and how much is that really important to how I can treat them? And I sort of had to take a step back and sort of say, tell me your story a little bit more. Again, it's about the patient, not about the disease. Okay, now that should clear up a few things around here. I want to spend a few minutes just making sure everybody's clear about definitions, and I'm not going to go through them all because you've got them in your handout, but they're really key. One of the things, June was talking how a year or two ago we did a pain training with some long-term care facilities in Montana, and there was one facility in northern Montana that actually took these definitions, and we haven't done it in our hospital yet, and I'm hoping that maybe we will get to this. They took these definitions and put them up in the bathrooms around the hospital. And I just thought that was just the best idea. So they took addiction and said, this is what it is. This is a definition that's agreed upon by the American Academy of Pain Medicine, the American Pain Society, and the American Society of Addiction Medicine. Okay. Some of the behavioral manifestations of addiction, and we'll talk about this a little bit more, are loss of control, compulsive drug use, continued use despite harm, and craving, although that's a little bit iffy. Some of the things that are not addiction, though, are these whole issues of physical dependence, tolerance, pseudo-addiction, and pseudo-tolerance. Okay? And I have definitions of all of these in there. The physical dependence, people are, if you are a persistent pain patient on pain medicines, you will have a physical dependence. Okay? My sister talks about this when she tries to cut down on her medications, and I call her up and say, why are you doing this? She'll describe to me the issues of that needing to take those medications because she cannot get off them, because she has a physical dependence on them. But she's not displaying signs of addiction. It's a very, very different thing. It's a normal, predictable physiological response, and you can get a withdrawal syndrome from it, and she describes it very well. Tolerance, you adapt to the drug so that you may actually need more of it. Okay? And she constantly talks to me about, why do I need more of this medication? And I go through this with her. Okay. A pseudo-addiction. This is, I think, a big problem that we are constantly facing in the hospital and in the office. It's associated with undertreatment of pain. And so these are the people that we think, oh my goodness, they must be addicted because it's that they're in the hospital and they have a PRN medication, they're in pain, and that 4-hour limit comes around and they push their bell and they want their pain medicine. And those people get labeled as addicted. Okay, we see it all the time, constantly. They're not addicted, their pain just is not being treated appropriately. The focus on obtaining drugs, aberrant behaviors. Behaviors resolve when the pain is managed. Pseudo-tolerance, again, need to increase the dose for reasons other than pharmacological tolerance. And those things may be a sign of addiction, but sometimes it's disease progression, a different disease, anxiety. They may be more active. We may be controlling their pain well enough so that they're being more active. Okay. And now we're going to switch gears just a minute. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. This is particularly pertinent in the state of Montana right now, where I think everybody knows we've got the Supreme Court ruling on physician aid in dying, but this is an old cartoon that I particularly loved. I'm going to turn the slides over for a little while to Deanna, who's going to talk about actually how we can assess pain in the office.
So, as Catherine said, I am Deanna. I work with Catherine in palliative care, and it's already been identified this morning about some of the barriers to pain, and I think this states the biggest issue, really, and that the management of pain begins with comprehensive assessment. And we'll talk a little bit more about that. It may seem very basic to you, but that's part of the role today, or part of our plan with this conference, is to sort of get everybody on the same page, whether you're a physician provider, a nurse, social worker, pharmacist, whomever working with patients, so we all are coming from the same knowledge base. And so some of the slides that I have may be, again, very basic for you. Let's see. I guess, let me just, oops. Uh-oh. Uh-oh. I'm goofed up.
You got it?
I think so. I think so. Yeah, sorry. And the first slide, I think I skipped over there, but really the biggest barrier that may seem ridiculous, but that the most common reason for unrelieved pain in the American healthcare system is a failure to assess it in the first place. And again, that may seem silly, but it's the truth, that if we're not asking about pain and if we're not adequately assessing that pain, then we're not going to know about it. And again, that seems sort of silly, but it's the reason for the greatest undertreatment of pain is not to assess it in the first place. June already talked about some of these dimensions of pain, in addition to being physical changes, also functional changes, and these other things that she's talked about. That it's a multidimensional assessment and multiple dimension effects that go on with unrelieved pain. And again, she's talked about many of those. So unrelieved pain, again, can have negative impacts on every dimension of a person's being. June also used one of the definitions here, and that is by Margot McCaffrey about the patient, the pain is whatever the experiencing person says it is, existing when he or she says it does. The self-report is really the best, single, most reliable indicator of pain, and it's one that sometimes we don't want to believe or to accept, but it really is the gold standard and the very basis of pain assessment. Whenever it's possible, you should try to elicit what a patient is feeling and asking them and talking them, and then either believing, or if not totally believing, at least accepting that this is what they're telling me in regard to where their pain is at that time. It really takes some commitment to engage with patients and really talk with them about, I'm here to work with you on your pain issues. I want to be a partner with you in your pain issues, educating them as you are engaging with them in regards to some of these terminologies and some of these terms that Catherine talked about in regards to addiction and physical dependence and other things. Patients really are pretty savvy these days, and they want to know more, and so educating them as you're working in a partnership with them will improve pain management and your ability to work with them. Again, June identified early on different dimensions to a person's being and also individual goals and function. I think that's a big part of assessment, is talking with patients about what are they unable to do now, limited by their pain, that they would really like to do. There have been several studies that have been done in regards to function and pain, and somewhere along a 5 or a 6, people start really dropping out in the major components of their function. That includes sleep, their mood changes, in addition missing work and other aspects of their lives. So function is a really big part of your assessment, and wanting to work with patients to identify the goals that they can increase or go forward on to increase their function. And that's going to be individual for everyone. For those with acute pain, it may be something that can turn around fairly quickly. For those who have persistent pain, it may be that it's something you're working at step by step, and may be very small, an incremental thing. Maybe they want to be able to sit up an hour a day when they haven't been able to. Or maybe they want to go for a walk when they haven't been able to do that. Or maybe it's returning to work. There's a variety of things that may be their goals. Using their language, tell me, show me, using those kinds of words, making sure that you're using the language they know. I often in a pain assessment will ask people about their pain, and they'll say, no, 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 they don't have any. And then I watch them move, and they're cringing, and they're groaning and stuff. And it's like, what is that? Oh, that's my ache. Okay. So, and it's true. You really have to find out what their language is. Is it an ache? Is it a pain? Is it something they've lived with for so long that they're no longer really identifying as a pain? So it's important to, again, find their language and make sure that you are engaging with them on that. I'll talk a little bit about cognitively impaired patients, but even it's been researched that even cognitively impaired patients may be able to tell you where they're hurting and how they're hurting in that moment. Maybe they won't be able to remember about it or think about yesterday, but in that moment they may be able to identify now. And you always want to start with a subjective assessment to best know. That's going to be your best guide to how a patient is doing. Treating every patient as if you had their pain. That's just having some empathy and some understanding. And then the quote here about there will be no drive-by pain ratings. And this is where I think we all, whether we're in a physician office or in the hospital, I'm a nurse, I want to run in there and get that person to give me a number. I want to know on that 0 to 10, what is your number? What is your number? I want to get in and get out. Or in the doctor's office, you're in a hurry. Catherine talked about 17 patients. That's a lot of patients in a day. And how much time can you engage with them, not only about pain but other things. But it really needs to be more than that drive-by pain rating. It needs to be more than just they're a 5. Well, what does that mean, to them? And how does it apply to their world, and how can you help them with it? Really quickly, assessment guidelines here. Again, asking regularly, asking systematically, believing the patient's report, or if not totally believing the patient, accepting what they are telling you. I think there's sort of a difference between believing and accepting, and for some of us, acceptance is a little bit easier to tolerate, I think. Choosing treatment options based on your assessment, and some of that comes out in the language that they will use, and I'll talk a little bit about that, but it may help you when you are doing a full assessment to identify the treatments that might be most appropriate for them. Delivering those interventions timely, and then not forgetting to reevaluate. I know in the hospital setting, it's one area that we definitely fall down in, is going back to reassess and to find out really how well something worked or didn't work. Components of pain, and I'm sure these are all, you all know these, but again, it's a very important part of a complete assessment. Location, where it's hurting, the description in the patient's words. Those are the things where they may tell you it's burning, it's stinging, it's aching, it's constant, it's gripping. All of those words are important because they may help you identify the type of pain. June talked a little bit about nociceptive pain and neuropathic pain. Those word descriptors will help you identify the treatments, whether they're pharmacological or non-pharmacological treatments that might be helpful for that person based on the words that they use to describe their pain. The intensity, and we'll talk about some intensity scales that we're probably all pretty familiar with, but that's important to get a baseline of how they quantify their pain intensity. Duration, when did it start, what aggravates or what has been a leaving of the problem, the pain problem, and again, as we've already identified, associated factors, whether those are side effects or how the person is impacted in their life, which all of those things really equate to their quality of life. And so you want to, again, work with patients to talk about their goals and their function and what is their acceptable level of pain. I think, somewhere along the line, we decided that maybe 4 on a 0 to 10 scale was unacceptable to everyone. And that's just not true. I mean, in working with patients, sometimes I will ask a patient, they tell me their pain's a 6 today, and I say, well, is that acceptable to you? And they say, well, yeah, it's better than it has been. It's better than an 8 or 9. Do you want to do better? No, I'm okay with a 6. So again, it's very subjective, very individual. It's not just because a person's pain is automatically now a 4 that we need to do something. For some people, when it's a 2, we need to do something. So it's really working with them to decide what is acceptable to them and trying to help them reach their goals. Again, some of these slides are a little redundant to things that we've already heard about today, but trying to use the language that is a little more acceptable to most of us, acute versus persistent pain. Went to a conference recently and they use these other terms of eudynia and maldynia. And, eudynia meaning that it's okay, that everything's all right, kind of even out, and so good pain is eudynia. And now that sounds kind of funny, good pain, but it's a sign of a symptom, or it's a sign of an indicator of something going on, and so there's something we can probably react to that probably will be able to turn that acute pain around when there's something specifically in regards to tissue damage or something. You may see a sympathetic response with that where there will be change in vital signs or sweating or other responses because the pain is so intense. Whereas persistent pain, previously known as chronic pain, is also sometimes called maldynia, and that meaning it's abnormal, meaning it's useless, as June said. There's no point to it. It's destructive, it goes on, and it's really not doing, and it's not an indicator any longer of a tissue damage situation. It's just persisting longer than the injury. And you may not then see the blood pressure changes and the heart rate changes that you do with acute pain. And I know for myself, sometimes when I see patients in the hospital who have persistent pain, and we are consultants to the providers that refer us, I will go back to that provider and say, this person has pain and this is what's going on, and I'll describe it very clearly. And the bottom line, that physician may say, well, what are their vital signs? And then I go, oh no, because their vital signs are totally normal, you know, and then I've had a surgeon once say to me, I'm not giving her anything, I don't believe it, her vital signs are normal. Well, she's got persistent pain, she's probably adapted. So I think it's, you know, again, really individual, and it's important to realize that there may not be some of those changes in persistent pain. There's pain assessment tools, and I know you're all familiar with these. Unidimensional, meaning that it's only looking at pain intensity. Numeric rating scale, the NRS is 0 to 10. That's probably one that you're familiar with. Other places use 0 to 5. Again, it's just an indicator for us to have, so we know if the interventions that we've provided have had any impact or not. But it only, again, is a pain intensity. It's not a thorough assessment. It doesn't tell you about quality. It doesn't tell you about what's working. It doesn't tell you about aggravation. It only tells you about the intensity of one's pain. There's other ones out there, a verbal rating scale, which is mild, moderate, and severe. I know you all know, working with patients, sometimes some patients are never going to understand that 0 to 10 thing. You can explain it, and they just don't get it. But if you listen to them and have them use their own words, they might be able to tell you mild, moderate, severe. That was my experience just this last week with a little older lady. She couldn't get that 0 to 10 thing at all. But she said, today my pain is mild. And how has it been? Oh, yesterday it was so severe I couldn't do anything. Okay, well that gives me a reference point to go on to see whether the things that we do implement make a change for her. Visual analog scale is just a line, basically. It's a 10 centimeter line, and a person marks themselves on that line where they see their pain. Faces pain rating scale, there's a Wong-Baker scale that is primarily utilized in children, although some older people can identify with that. Older, I won't quantify that, but you know, it has to be individual again. And there's also another pain faces that's 1 to 7. And again, we just want to find that number, but also what is acceptable to that person in regard to that number. Multiple dimensional tools, I just listed a few of them there. There's a lot more of them out there. They look at more than just pain intensity. They look at interference with function, which we've already talked about. So they're important tools. They're lengthier. They're hard to get people to complete, but you can use them in private practice, for example, initially maybe, and maybe it's something that you can have the person take with them or have them fill out as they're waiting in the office area for the timely doctors to show up. And then it gives you a baseline for working with them in the future, because it's more comprehensive. Again, it talks about their interference with function, what their quantity of pain or quality of pain may be, different things in regards to their pain comprehensively. Behavioral pains, these are behavioral pain assessment tools. And again, remember that the first and most important is the subjective, how does a patient, and when they can tell you in their own words. But sometimes we have to resort to behavioral pain assessment tools. There are many listed here. Most of these are for the person who has some cognitive impairment. Behavioral pain assessment tool, meaning you actually have to watch the person. Many of these tools are used in nursing facilities, but sometimes we use them in the hospital, sometimes in outpatient settings, but you actually have to watch the patient's behavior. You can't always know that what they're their facial grimaces and things like that are making a difference. They may be, and they may be evident from some of these tools, but really the best thing is watching a person and knowing that their behaviors may change over time. And so it's a change in their behaviors from what they used to be. For example, in the nursing home, maybe you have someone who's normally pretty social, they go to lunch, they interact with other people, and now suddenly there's a change. They're wanting to stay in their room, or they're sitting in a chair not wanting to move. So it's a matter of actually watching them and assessing them and seeing if there's a difference in their behavior that might be an indicator of pain, and when in the case where they cannot tell you directly. But do remember to ask, because again, not just because someone has dementia, mild or moderate dementia, does not mean that they cannot tell you that they have pain. There have been studies that have proven that the best indicator of their pain is to ask that demented patient, especially those with mild or moderate dementia. It's also not true that central nervous system changes that do happen with dementia, that those alter the ability to feel pain. That is not true. Just because someone has dementia doesn't mean that they cannot feel pain. They may not be able to express it, but again, we want to look for the behaviors that may make a difference. And those behaviors may be subtle, but for those who work with patients consistently, they may be able to identify those. So there's many tools out there. Again, most of these are for cognitively impaired, those with dementia or Alzheimer's. The FLAC is actually a tool that is for faces, legs, activity, crying, and consolability. That's actually was developed for children, I believe 2 months to 7 years, something like that. Hierarchy of measure of pain intensity, again, the standard is a patient's self-report first, then thinking about pathological conditions or procedures that might be causing that pain. Then it's not to say that you know more about the person's pain, but it is to take into consideration what is being done to them or what is going on with them. There's a concept called assume pain present. And assume pain present means that, given this assessment of the person and given assessment of what's going on with that person, that we can assume pain is present. An example of that might be if you have a patient who's in the ICU, maybe it's a trauma patient who is now paralyzed on a paralytic and maybe getting sedation also, but they're not getting anything for pain. Well, if you're a trauma patient, probably you've got pain, but somehow or other we forget about that. So there's certain circumstances where you need to use your judgment and assume pain is present. I use the example of got referred to see a patient who had had a hip fracture and a hip repair. She'd been in the hospital for 3 days. She had some dementia. When I went to see her, I looked at her medical record, her medications, and guess what? In those 3 days of pain, fracture, or hip fracture and hip repair, she had had nothing for pain. Absolutely nothing. This is a true story. It breaks my heart. You know, if it was me or if it was my mother or whatever, you know, I think a hip fracture is painful and a repair is got to be painful. So I would assume pain is present in that kind of situation, even though she may not be able to tell me, and empirically try what is ever available for her to hopefully improve her overall comfort. So assume pain present is a concept. We don't use it at our hospital you cannot use it as a pain scale or anything like that, but it's certainly a concept that we hope everyone understands. Behaviors, again, looking at people's behaviors, these are in the hierarchy of how you would assess pain. Reports from family and other close caregivers, sometimes those come into play, and also physiological indicators. Reassessment is very important. Again, that way you know what's going on. You want to work with that patient to see how things have changed for them with your interventions, if it's acceptable pain now or improvement in their overall function. There are what's referred to as the 4 A's of pain management. I think Catherine's going to talk a little bit more about this. But analgesia, meaning that you're asking them, okay, how did this pain medication, for example, work? Or also thinking non-pharmacological. How did this intervention of biofeedback work? Or how did this intervention of physical therapy work? Or whatever it might be that you've suggested, how does it work for them? So every time assessing a patient in regards to these 4 things, the analgesic effect, the activities of daily living, again, that's their function and other things that go on in their world, in their relationships, in their ability to work, a variety of things that make us all human and interactive and individuals. Adverse reactions, of course, looking for side effects, always thinking about constipation. That's another area where I think we fall down, and I don't know. I'm sure the pharmacists will be talking about that today. Aberrancy, and that being aberrant behaviors, is one thing. We don't want to be paranoid, or I don't think we want to be paranoid about that everybody's out there to misuse medications, but you want to be thinking about some of those behaviors. That could be as subtle as someone kind of hoarding their medications, or maybe increasing their medications on their own without being authorized, to actually very blatant behaviors, things like forging scripts or criminal activity. So some of those things could be identified when you're reviewing with your patients on reassessment. Remembering multimodal approach to pain treatment, again, using non-pharmacological. I think that's become more acceptable these days. There's a lot of patients out there that go to massage, that go to chiropractors, that do all kinds of different therapies. And I think that it's important to embrace those things, because it will help people, especially with persistent pain, to be able to live and be comfortable and seek out those other modalities that might be helpful to them besides medications. And documentation, being sure that you're documenting whether in your private practice or in the hospital, because it's the only way for you to know how things are working, and it's the only way for you to know what needs to be done next, and to validate what has happened for that person. So I think that's it for me.
Oh, wait, Corey. Add the cereal first and then the milk.
The directions.
Deanna's a cereal. I'm the milk. Thank you, Deanna. I don't know. I don't know. You're a treat to work with, Deanna. I want to just mention a couple of things. You're going to be hearing more about multimodal therapy, which is really become a keystone of some of the things that I try to do. There are a couple problems which I'm sure you will hear about, one of which is who pays for it. And this is a major issue for a lot of my geriatric patients, of what gets paid for, and I just don't have the access that I need because they can't afford it. So that's an issue. It also brings up one of the things that I'm lucky enough to have in this community that really has been happening really over the past couple of years, is actually getting some more resources in our community for me to refer my patients to. So I'm now much more familiar with who will actually take insurance for massage or physical therapy or whatever. We have a couple of counselors now out in the community who actually do some chronic pain management. So just make sure that those of you who go back to your communities, try to find out what resources are out there, because I think that we're actually getting a few more resources out there, which is really helping me in taking care of my patients. So I want to spend the next end of this talk talking about the elephant in the room. There are two elephants in the room whenever I give a talk. One is that people do actually die, but that's a whole nother talk. And then, but for this talk is, the risk of opioid abuse. How do we in primary care assess this, and what do we do about it? And I will say, I will admit right up front that I'm not sure in our practice we do a great job of it. We try. We definitely try, but one of the issues that, and I know there are some of the providers that I work with in this room, and I would challenge us actually to try to find some time when we could actually sit down as a group and say what's going to be an organized approach to doing this, because we've talked about it, but we're not that organized in terms of doing this. I'm going to talk about function. We've talked already about the patient and not the drug, that it's really the patient that's important. So screening we do think that screening can prevent abuse. I'm not going to present a whole lot of evidence-based literature here, because I will tell you right up front, it doesn't exist. Okay? So you can read stuff over here, you can read stuff over here. What best practice, maybe it's out there. Evidence-based, I think maybe in the persistent pain arena, where you've got an interdisciplinary clinic that Randall's going to be talking about this afternoon, there's probably a little bit more evidence-based material, but for us in primary care, there's not a whole heck of a lot out there. So there are reasons why we don't screen. lack of confidence in addiction management capabilities. So what do we do if we identify a patient who not only has persistent pain but has a problem with addiction? Where do we send them? What do we do with them? That's a big issue, I think, across the country and certainly in Montana. There's one place where people can go in Montana, but they have to be off all of their pain medicines before they can go there. Well, I'm not sure that really helps me, and I know it doesn't necessarily help my patient. Time limitations is a big issue. It's really, really a big issue. And then there are some fears about patient sensitivity surrounding substance abuse issues. And in my opinion, one of those fears is that many patients who have persistent pain have been maligned. I'll go back to my sister. She had to go through 3 or 4 doctors before she could actually find a physician who was willing to say, I will give you enough medicines for you to get through a month or two, because I really don't think that you are abusing these medicines or are addicted to these medicines. But this was in California, and she had a similar experience. She lives half time in California, half time in New York, and she had a similar experience in New York. So I think there are some real issues about patient sensitivity. Okay, so there are many tools out there, and in your appendix I've given you some of those tools, and again, this book, Avoiding Opioid Abuse, has other tools in it. Pick one that'll work for your setting. I'm not sure that we've actually picked a good one in our setting yet, partly because we just haven't been coordinated about it. Make it brief, make it easy to administer and interpret. Decide, is a patient going to fill it out before they come in? Are you going to fill it out with the patient? What about different age groups? And there are some real variations. So I see mostly patients who are 65 and older, and I really don't like you until you're 75 or 80. But tools for them may be very different than for the 20-year-old who comes in with persistent pain. See if you want to gear it to opioid abuse rather than other substances such as alcohol. Is it self-administered? Is there a best tool? And we don't know. Okay, the research is still pending on this. So whoops. Uh-oh. Deanna. There we go. Okay, so there are a bunch of different tools out there. And again, I'm not going to go through all of them. The CAGE is one that I grew up with. It's specifically around alcohol abuse, but has now been adapted a little bit for people who are on opioids. They have various sensitivities and specificity. And again, this is the name of that book, Avoiding Opioid Abuse. I really recommend it. And then there are some specific opioid tools. There's an opioid risk tool, which you have, and then there is the SOAP, which stands for, and I always have to go back to what it stands for because I can never remember, Screener and Opioid Assessment for Patients with Pain, and there's a long version and a short version. And it is for patients with persistent pain. I'm going to be very interested. Kaiser in California is now using this across their settings, so I'll be very curious to see what kind of information they come up with and how useful this tool really is. I commend all of you to take a look at it. I want to tell you about another website that's been really useful to me, which is called pain.edu. And that's where I first heard about the SOAP. And you can get on there, and they have a whole bunch of free tools for you to use and a whole bunch of great information. So I really recommend it. Then they will send out to you. I must weekly get an update from them about various things. I think it's important to remember what our goal is for assessment. It's not to deny pain treatment to patients who need it. Okay, that is not our job. Okay, it is to set and maintain a level of monitoring proportionate to the individual's risk. And again, in Lynn Webster's books, he talks about low, moderate, and high risk, and there are various criteria for that. And this is really key, I think, because patients who are at high risk still have the same right to have their pain under control. Okay? Just because they are at high risk, just because they may have an addictive problem, doesn't mean they should not get adequate pain control. And that's something that's really, really hard for us to get to understand. And I think one of the ways to understand it is to recognize that this person may have at least two diseases. They may have a persistent pain disease, and they may also have a psychiatric or psychological disease that involves addiction. In addition to that, they may have a third diagnosis, which is just they may also have a depression, they may have a borderline personality. So conceivably, this person could have three diseases. So I think we need to really pay attention to that. And it makes those patients are very difficult, no question about it. So monitoring initially, conduct a thorough patient evaluation. We talked about that. An individualized treatment plan. And I'll talk about that in a minute. Access consultation is needed. Luckily, I feel very lucky to actually have some people now in the community that we can use. Periodic review of treatment efficacy, document. I want to say a word about documentation because I realize that as I go on in my day with our electronic medical records, the further I get in the day, the less I document. There is no question about it. You know, I'm like, okay, 2 sentences, you know. So it's a real issue. And do templates help? I don't know. We have a couple of pain templates. In my population, my geriatric population, I'm not finding them that useful. I think we also need to revisit them and maybe redo them so they're a little bit more user-friendly. I think it's, you know, we talk about documentation, how important it is. We've got to do it. I know that as a primary care provider, I fall down on that. Treatment goals are really key. So what are their goals? Do they want to feel less pain? Do they want to feel less groggy or sedated? Is cost an issue? There's a new drug out there now, Nucynta, which the drug rep may be out there, I don't know, but it's actually not a bad drug, but it's very, very expensive. Do they want to avoid dependence on drugs? And finally, function. And I know Deanna talked about this a little bit, but this is really key. What does this mean for the individual patient? Because it's very, very different for each person. So there's a 68-year-old man with severe degeneration of his spine. He's been treated with multiple spine fusions, but still has decreased function because of pain that occurs during amputation. All he wants to do is be able to walk 30 minutes a day without excruciating pain. I have one patient who comes into me. She came in and said, I can only stand for 10 minutes. I've now got her standing for 20 minutes at a time. She is ecstatic. She's so happy. For me, that would not necessarily be my goal, but that is her goal, and it's not about me. There is a lot of talk out there about opioid treatment agreements. Who should have one is still a debate. Should it be signed by, it probably should be signed by both the patient and providers, and the question, and we don't know about their effectiveness. There's one provider I know out in our community who, no matter who you are, you get on a contract, period, or a treatment agreement, which is probably a better word because contract implies legality. I'm not sure that's the best way to go about it, and certainly in my population, I have very few people on treatment agreements. Some of the providers in my office who see younger patients have more people on treatment agreements, and it may be appropriate. There's a copy in the appendix of a treatment agreement that you can adapt to your setting. Deanna talked about the ongoing monitoring. So analgesia, what was your pain level? It's worse during the past week. When you compare the effectiveness of your current treatment with previous treatment, was it better? Okay. And is it good enough to make a real difference in your life? We're getting back to that issue of function. Activity, sleep, relationship with others, mood, all of these things I think we need to be looking at because they're really key. I had a patient who came in yesterday who was having incredible pain, and I learned this actually from Nelson, had incredible pain when she woke up in the morning, and she was having more pain in her hip, and then as the day went on, she got better. Well, I said, so how do you sleep? What kind of position are you in? What do you use to support yourself? And it may be as simple as figuring out what she needs to do with her positioning in bed, whether she needs more pillows, whether she needs a different bed, that kind of stuff. And I think Nelson may address that later. And then adverse events. Can you tolerate the current pain medicines? Are you experience any adverse effects from your pain relievers? And then constipation. A constipation is just that is the rate limiting step in patients taking pain medications. And it is just such a huge issue. And it's a huge issue in the hospital. And it's a huge issue in the nursing home. I mean, I cannot tell you the number of patients who go home from the hospital after having 5 days in the hospital, and what's their number one complaint? I didn't have a bowel movement the entire time. And I realize we may not want to be talking about this, but this is huge and has been an issue throughout my professional life. And I'm so excited if I go into a room and somebody's actually had a bowel movement. And I know that sounds really silly, but it makes a major difference. Potential aberrant drug-related behavior, and there's a list of that in your handouts. Actually, there's a sheet in there called Pain Assessment and Documentation Tool. Again, it comes from Pain EDU, and it has on there some of these issues. Don't assume anything. Don't, particularly with younger patients, don't assume that everything's okay. Use open-ended questions. We tend to sort of say, well, so you're whatever. We close off our questions. Try to open it up to what does that mean to you, or what's been happening, or what's going on. Express empathy, observe behavior, corroborate patient statements if possible, and that means having somebody else come in. Okay? Most of the time, I don't see my patients without somebody else in the room because some family member, because most of the time with my patients, they can't always tell me what's been going on. So then there's the issue of low risk, moderate risk, and high risk. That again, in my patients, many of them are really low risk. I have probably a handful of patients that I would identify as moderate risk. The high risk patients, they're pretty easy to identify, and actually they tend to be on the younger side, and I don't see that many of them, but my friend over here, Joan, probably sees a lot of them. So she's got to gear her practice to what's going on with those particular people, and those people may need the treatment agreement. So the managing these patients with aberrant behavior, you may need to do frequent visits with counts of medications. You may need to do drug screening, and there are some issues with drug screening that may or may not work. Use of opioids that have less abuse potential, so we're trying to avoid OxyContin, oxycodone, but I'm not sure that there are any opioids out there that have less abuse potential. If you can enlist a third party. Now, there's a problem with that because sometimes that third party is part and parcel of this abuse behavior. We had a patient on hospice whose daughter was actually taking her medications, and so that, it's a problem. Psychiatric disorders, really look at that and work on treating that. I have one patient right now who I'm seeing who's in her 70s, and we're really struggling around her use of her opioids because it's very clear, and we've had very upfront conversations, that she's using these opioids to reduce her stress. And we really have to talk about the difference between pain and stress and what's going to work for the stress versus what's going to work for the pain. Big problem. Have an exit strategy. There are some people that you just cannot take care of anymore, that you're going to have to get rid of in your practice, or have them say, this is not working for me and this is where you have to go. And we have, actually in our office, we do have a policy of the steps we have to go through, because we're very careful about this, where we say we can no longer have you as a patient. It's not a simple thing at all. But look at having a policy in your office. Drug screening, again, this is actually something that I don't do very often, but other providers in my office do. it may serve as a deterrent to inappropriate drug taking, but we're not sure. I know Randall uses it a lot in his setting because he's seeing more of the people who have persistent pain with multiple issues. It may assist with diagnosis. It may provide some advocacy for a patient demonstrating compliance and support your decisions. There are some limits. There's a lack of sensitivity of tests. There's false positives and negatives. The results may be influenced by technique, and there are some possible regulatory problems. So what is insurance going to say about this? What are the law enforcement people going to say if you come up with a test that's not appropriate? So finally, I want to say, while it's not rocket science, it does take a certain amount of consistency and compassion to best help our patients. And the other thing that it takes is time, and I see that as actually one of the biggest factors. If we could really take a little time out of our really busy days when we're being pushed for productivity to come up with a system that will work for us, I think that would be where we need to go, but it's very difficult. So we're just starting on this process. I'd appreciate any thoughts or any suggestions that people have, or any system that works for those of you who are doing primary care. We're going to take a quick break and then come back. And please, if you have questions, write them down and we'll get to them.
Hi, yeah.